Welcome to this webinar. And today we'll be briefly discussing about the approach to acid-base disorders. So you do get a lot of questions on this in your NEET PG, as well as this is very relevant for us in practice later. So what I'll be doing is a brief overview of the acid-base physiology, and then we'll go on to a systematic approach to diagnosing acid-base problems, as well as then we'll look into a uh, few cases that are relevant to us. So we'll look into the cases and try to understand how do we approach these uh, acid-base problems that are there. So if you look at the acid-base physiology, the precise H plus ion regulation is essential for the normal functioning of variety of enzymatic systems. So it's very important that we have to maintain the pH of that. So the normal H plus concentration is measured as 0.0004 milliequivalents per liter. That's what is measurement, and we express it in the pH is the log of the H plus ions that we have. So the normal pH, when we say generally it is 7.4 is what we consider as a normal pH. That's where we are looking at. Now, if you see, what do you mean by an acid? So in physiological terms, acid is a molecule that can donate a H plus ion, and base is the one which accepts the H plus ion. So we'll discuss this in a little detail. So the pH of the body and the body fluids, the blood or the interstitial fluid or that is maintained by three systems which are important. One is the chemical acid buffer system. This is the primarily. This is like an active buffer system that is in place. The chemical acid base buffer system. Then you have the respiratory and the kidney, which come into place whenever there are certain abnormalities. They come into compensate sort of things. So these are the main things that we go on to. Now, if you look at the respiratory component and the metabolic component, so respiratory component, obviously, we are going to breathe in and breathe out. So carbon dioxide is the one which is exhaled by the uh, uh, respiratory system. That explained when we have an expiration, carbon dioxide is exhaled. Now, this carbon dioxide is produced by various, oxidation of the various carbohydrates and the free fatty acid, which is there in the serum that could, interstitial space. It comes into the respiratory system there, and this is, the carbonic acid anhydrase that is there, the carbonic anhydrase, and that is going to split the bicarbonate or H2CO3 into carbon dioxide and H2O. H2O gets absorbed and the carbon dioxide is exhaled. Now, if you look at the metabolic component primarily, you have the intracellular buffers, that's the H plus ion that's there, and then the various other cations which are present, which go in through the renal. So, majority of them are excreted in exchange to either sodium, potassium, or sometimes there is a co-transporter that could happen with the bicarbonate or chloride, and that's how you have the both the metabolic component as well as the respiratory component, which is continuously working in order to maintain the homeostasis that we are looking at. Now, the chemical acid buffer system, that's a very, very important buffer system which acts immediately. Even before the metabolic or the respiratory changes happen, the chemical acid buffer, which is the primary thing that happens within few seconds. So please remember, if they ask you, what is the first ion buffer system which comes into action to counteract or to rectify the acid base disturbance is the uh, chemical acid buffer system. So the buffer with the H plus gets added, and that becomes the H plus buffer that is there. So the most important one that we have is the bicarbonate buffer system. Remember, bicarbonate is a weak acid. The bicarbonate salt most often that we get is the sodium bicarbonate that's there, and that combines with the H plus, and that results in the formation of the H2CO3 that is there. So when this H2SO3 will be acted upon by the carbonic anhydrase, releasing the carbon dioxide, which is washed out through the uh, lung, whereas the H2O would be eliminated eventually by the action of through the kidney possibly. Whenever the bases are excess, so what happens when the base is excess? So NaOH will be formed. And that will be excreted through the possibly the renal system that is there, that is going to be excreting it. So the bicarbonate buffer system is one primary. The second buffer system, which is important for us, is the phosphate buffer system. Here it consists of the H2PO4 and the HPO4 minus that's there. So these are going to neutralize the acid either when there is an acid excess or sometimes the base excess whenever it is there. It forms into the compounds which can be excreted through the kidney. But please remember the phosphate buffer system is little weaker compared to the bicarbonate. The bicarbonate buffer system is the most stronger. The other buffer system that we have is the hemoglobin. Remember the whenever there is an acidosis or an alkalosis or hypoxia, you have the oxygen dissociation curve which shifts, so which enhances the binding to the hemoglobin. You could have the bone buffer system and the ammonia buffer system which are there. So these are the other chemical buffer systems which help us to regulate. Coming on to the respiratory regulation of the acid-base balance. So action starts in a few minutes. Remember the chemical buffer systems is in few seconds. The respiratory is the second that's going to happen, and it is more powerful than the ECF buffer systems put together. So respiratory system can, hyperventilation can happen or acidotic breathing can happen, and that can cause a significant change without in seconds that with a few minutes that's happened. So whenever the pH decreases, the respiratory center will, get stimulated and hyperventilation will happen, resulting in a carbon dioxide washout, restoring the pH. So this happens very, very soon and very rapidly. And whenever the pH increases, there is a depression of the carbon respiratory center, resulting in hypoventilation, and the carbon dioxide now builds up in the respiratory system, and that's how the restoration of the pH happens. So this is the respiratory regulation of the acid-base balance, which happens within minutes, and it is very strong compared to the other systems that we have. Response to alkalosis, we do not usually see so often. How we see whenever there is a metabolic acidosis, you get the classical Kussmaul's respiration, isn't it? The rapid, deep respiration to wash out the carbon dioxide. Whenever there is alkalosis, we do find, unless it's very severe, we would not find the patient being, shallow breathing, etc. may not happen there. But the acidosis compensation, which we get, very, very clear. Now, very importantly, the function of the respiratory mechanisms is greatly governed how the lung is. Supposedly, the lung is damaged either due to pneumonia or an ARDS or a chronic obstructive airway disease, airways are obstructed. In such things, this mechanism does not occur so effectively. So that is the problem with this mechanism that we are looking for. So impairment of lung function itself can impair the acid base. You can have acidosis that could happen, or alkalosis could happen because of primary lung disease. Also, that's what you have to remember. Coming on to the third and possibly the most, complex form of the acid-base balance, because there are multiple things that happen at the renal system, which would usually happen a little later compared to what happens in the respiratory, which happens faster. Now, to maintain a normal plasma bicarbonate in the face of constant accession, the metabolic acids, the kidney must either reabsorb the bicarbonate so that H plus is neutralized, or excrete almost 10 100 milliequivalents of H plus which is generated. So supposedly there is a acid added into the system, it has to excrete more. So that is where it is going to happen. So primarily you can see it in the proximal convolutional tubule where the reabsorption of the bicarbonate is happening. So you can see that the reabsorption of the bicarbonate, again the carbonic anhydrase enzyme is the one which is going to be there here. And you can see that that is going to act there and make sure either through the symporter or through the co-transporter, the bicarbonate is reabsorbed. The filtered bicarbonate is reabsorbed. This happens at the proximal convoluted tubule, and that is where the first mechanism is happening. The second mechanism, as I said, the kidney has to excrete almost around 100 milliequivalents of the H plus, and that happens at the distal tubule. So you can see that in the distal tubule, the H plus is getting excreted via the various co-importers again. So that is where it is going to get excreted. So variety of cells are there. I'm not going to go into the detail of it. But please remember in the proximal tubule is the bicarbonate absorption, and the distal tubules we are having the excretion of the acid. So if you have a disorder of the proximal tubule, you will have certain abnormalities. If you have a distal tubule defect, we will have certain amount of abnormalities. The acidification of the urine may be affected in one of these that we could see there. So after knowing the basic physiology, let's please understand what is this acid-base disorder. Please remember, it is not an ABG alone that we are looking at and making the diagnosis whether it is acid-base disorder. Very, very important is the history, because a particular acid-base disorder, acidosis, can occur due to maybe 10 to 20 causes. Unless we take the history, we will not be able to make out the cause. Unless we do an examination, we will not be able to make out the cause. So good history is very important about what the patient is on, what is the medication he is on. Various drugs can produce abnormalities. If there is any diabetes, then acidosis could mean diabetic ketoacidosis. If it's a CKD, we know it could be metabolic acidosis because of that. If the patient has COPD, then there could be the PCO2 might rise. So that can be a cause there. We can see that. Physical examination is very important because your Kussmaul's breathing, which I told you, that is the rapid, deep breathing, which washes out the carbon dioxide, usually happens when the pH is around 7.1 and less. So by looking at the patient itself, we can say what is the pH. We don't have to wait for the ABG report there. You can make out that. Similarly, if a young patient is come with hyperventilation, then this is the patient is going to have a respiratory alkalosis because of carbon dioxide washout that's happening. So physical examination is paramount important. This patient with respiratory alkalosis would have low ionized calcium, and they can have come with tetany. So you can make out that. So whenever a tetany is there, we know that there could be associated respiratory alkalosis. Very, very important is the volume status of the patient, hypovolemia, hypervolemia, or euvolemia. So it helps us a lot in management. And again, remember, whenever the volume status is high, so there's a lot of fluid in the uh, compartments that we are looking at, various, be it the sodium, be it the potassium, usually sodium related thing and the H plus related thing would vary in that. Ventilation, I've already discussed. Sensorium is important because quite a lot of drugs can cause coma and also metabolic problems, acid-based problems, which can help us to diagnose. And very important is the blood gas assessment, which we are going to discuss in a little detail. And then once we have identified what is the abnormality in the blood gas, is it a metabolic acidosis? Is it a metabolic alkalosis? Is it a respiratory acidosis? Is it a respiratory alkalosis? We have to identify what is the cause. Because we can treat these abnormalities, but unless we treat the cause, the abnormality will not completely clear. So we require to identify that also. So that is very important for us in identifying what is the cause for this acid-base disorder. So generally, what are the indications for acid-base disorders or ABG analysis? So always patients who are on ventilation, you would want to identify them. A patient who has acid-base disorders, possibly an acidosis, a renal failure patient. If a patient is already on ventilator, you want to monitor. If a patient has hyperkalemia or hypokalemia, we want to know what is it, acidosis or alkalosis. Also, very commonly we do ABGs, especially in ventilated patients or perioperatively sometimes you would want to look for. So these are the indications for ABG. Majority is because of the ventilation or the acid base. So it's important. So normally we do it in the radial artery and it can be done in other arteries also. Femoral is easily done. Radial is ideally done there. You can do through other arteries also. So arterial blood gas is needed primarily for the estimation of the partial pressure of oxygen. That's what you have to remember. VBG is okay for all other purposes except for PO2. The VBG can give you the enough clues and VBG can be easily done rather than the ABG. Certain technical aspects we have to understand. We have to do it immediately. If you want to transport, it has to be transported in a cooled ice. Do not put too much of heparin. You have to put maybe a drop or less than heparin because the anticoagulant itself can have effects of it. Air bubble should not be there, otherwise you can have a false elevator. And again, remember the machine will calculate the pH, PO2, and PCO2. The HCO3 is calculated. HCO3 is not given. HCO3 is calculated based on you have this Henderson-Hasselbalch equation which you have learned in biochemistry. That's how it does. So this is how we do the ABG. So in the radial artery, that's what you're going to do it. Some of you would have practiced it during your internship. And very important, before doing that, you have to check for the Allen's test. It's important because you want to look for the patency of the, uh, the radial and ulnar artery. So you press it and see whether it is flowing there. If it is compromised, then don't do the ABG there. So Allen test has to be done before we do ABG. So never forget to do that. You always have time for that. If there is a compromise, then you can look for other side. You can check it in the other hand, or you can also do it in the femoral. Femoral is pretty easy. You can do it there. Only thing is you have to give a good compression. That's important. So immediately load into the autoanalyzer and you will get the various parameters. So this is how an arterial blood gas report would appear. So you can see that the pH, the PCO2, PO2, these are the ones which are primarily that they are going to give it. Then the bicarbonate. And also you could get other findings like you have the base excess that's there, the electrolytes, and some of the machines you get the hemoglobin as well as you might get the glucose and lactate also. So based on what machine you're using, you will have the various various patterns that you get. But primarily we need to know the pH, the PCO2, the PO2, bicarbonate. With this we can make out, and the base excess maybe helps us in sometimes. It can help us identifying the acid-base disorder that is there. So before we go on to identifying the abnormalities, we have to know what are the normal values. So that's very, very important. Uh, we have to see the pH. So please remember the pH is normally 7.4 plus or minus 0.03. That is, so 7.37 to 7.43 is what we could get it. Venus is little less. So please remember Venus is 7.38 plus or minus 0.2. So that's what is a normal. The PO2 should be anything above 90. So 80 to 100 is normal. The Venus, you can see grossly that the PO2 is very less. So that's very important difference. The PCO2 is almost same, 40, 45 that we're seeing there. Base excess is almost same. The saturation, again in arterial, you'll have 100. The venous can be maximum is 70. Bicarb is almost same. Arterial is 22 to 26. Venous is 24 to 27. So what is important is the venous blood gas is not good for the PO2 and SO2. SO2 you can do it from your oximeter, so you don't require that. The PO2 in the venous is obviously very low, so it's a venous activity. Otherwise, you can use the venous blood gas for monitoring things. Now, again, very importantly, certain points to remember. One is what we call it as a steady state. The steady state is where the compensation or where the equalization of things happen. It would normally take around 3 to 10 minutes without any overt disease. Okay, primarily if there is a first time happening, it would take pretty rapidly. It would occur the steady state. However, if there is a chronic problem, especially respiratory, this compensation would take much longer. As I told you, the heparin, if you give too much of heparin, you may have a falsely low pH and the bicarbonate. So you should be careful about that. So giving anticoagulant, you just require 0.05 ml per 1 ml of blood. Decrease, if you delay the processing, so it decreases the PO2 and increases the PCO2 more the time spent. So you can store it in cold, but very, very important, ideally to be done bedside or else within 15 minutes, it has to be processed. Otherwise, our values which we get will be false. So if you remember that in the air, the PO2 is around 160 and in the PCO2 is around 22. So if you have an air bubble that is going to come, then you will have some values which are going to be fallacy. So you know that the PCO2 is lesser and the PO2 is more there. So that would either mean the patient is on ventilator or there is an air bubble that has come in. Venous or arterial blood, I told you, you can identify it when you're doing it. A spurt of blood happening is always arterial blood. Darker blood is a color, which always say it's an arterial blood. The SpO2, you can check it in the pulse oximeter. If it is corresponding to the ABG, then it's arterial blood, otherwise no. Also, you can simultaneously take a venous blood parallelly and check whether the sample is adequate or not. So sometimes if you have a doubt, especially the femoral, radial it's okay. Femoral you can always sometimes puncture the vein there and you can get a sample. So you can confirm it. But I told you venous blood is enough for most of the values except for the saturation that we are talking about. Now, Something that we look for before we start reading the ABG is whether the pH and the H plus is corresponding that we see here. If you look at the pH 7.4 corresponds to uh, H plus of around 40 that you're seeing here. So you have to thus do that something called as multiply into 1.25 for the pH is becoming lesser and divide by 1.25 for the pH is becoming more. So if you see 7.40, you're seeing the pH is around 7.40, it is 40. If it is 7.39, then you know the H plus should be around 41. If it is 7.38, it should be 42, 7.37, it should be 43, likewise. So if this is happening, then we know it is not compensated. This is what is the proper value we have to analyze. So this is some basic before we go on to analyze the ABG. Some definitions, as I said, pH is the negative logarithm of H plus. PO2 stands for partial pressure of oxygen. PaCO2 is partial pressure of carbon dioxide. SaO2 is the percentage of oxygenated hemoglobin in the blood. And B is the base excess, that is the amount of H plus that has to be ordered in order to bring the pH normal, right? And acidemia is when the pH is less than 7.36. Alkalosis is when the pH is more than 7.44. Acidosis, when we say the primary pathophysiological process is that the H plus has increased and that's why the pH has decreased. When we say alkalosis, it is there is a H plus is decreased and that's why the pH has increased. Metabolic acidosis, where the primary process causes the HCO3 to fall, and the metabolic alkalosis is where you have the HCO3 is to rise. So these are certain definitions that we have to be aware. Respiratory acidosis, where the primary process which is causing the PaCO2 to rise, and respiratory alkalosis, where the PaCO2 falls. Mixed disorders, where you have both respiratory as well as metabolic problem happening, or you have a mixed problem of alkalosis and acidosis together. Now, always remember there is a compensation. Now, whenever there is a metabolic problem that's happening, the respiratory system tries to compensate so that the pH comes to normal. So, we will have to look for whether there is a compensation or not. Now, the first question that we are going to ask is, does the patient have acidosis or alkalosis? So, that is how you look at the pH and you can make out that. So, if the PaC2, what is the PaC2 and what is the abnormality in ventilation if you are seeing for? If the pH is less than 7.35 and the PCO2 is high, no, we know that it is acidosis, but the PCO2 is high, we are dealing with the primary respiratory acidosis that is there. So that's the first abnormality when you're looking at the PCO2. And if the PaCO2 is going to be low and the pH is high, we are dealing with respiratory alkalosis. So what we are looking at whenever a respiratory problem is happening, so you saw acidosis and alkalosis, the pH as well as the PaCO2 is going opposite, right? So the PaCO2 is going high and the pH is going low. So it's opposite directions. That's how the respiratory problems will occur. Now, if you see the metabolic problems, we are dealing with HCO3. So there it's the metabolic problem. If the pH is less and the bicarbonate is low, it is metabolic acidosis. And if the pH is more and the bicarbonate is more, it is metabolic alkalosis. So remember, in a respiratory problem, it is opposite. That's the mnemonic that we have, what we call it as the Rome. So here it is. In the respiratory, it is opposite. So pH is rising, PCO2 is falling, it is alkalosis. Please remember, pH rise is always alkalosis. pH is low, it is acidosis, but the PCO2 is high, that is respiratory acidosis. Whereas metabolic is always equal, pH rises, HCO3 rises is alkalosis metabolic, pH falls, HCO3 falls is metabolic acidosis. So that's the mnemonic for acid-base disorders where you say it is respiratory is opposite and metabolic is equal, that's happening there. So whenever one of the mechanisms is failing, either metabolic or respiratory, there is a compensation that's going to happen. And the compensation usually is the other. So supposedly you have a metabolic disorder, the compensation is going to happen through the respiratory mechanism. And when you have a respiratory disorder, the compensation is going to happen through the metabolic problem. So what is the compensation? What do you mean by that? So whenever a primary acid-base disorder exists, the body attempts to try to pH to normalize. Why the either base? Like as I told, if it is metabolic, it's taking the respiratory. If it is respiratory, it is going to take the metabolic compensation. So it is going to try to get the pH towards normal. Now, how do you identify that? I have already told you pH and H plus ion I have calculated in the first formula. So if you see it is not matching, then you know there is some compensation that is going to happen. Now, how is it going to compensate? So remember, metabolic acidosis, the compensation is your increased ventilation to wash out the carbon dioxide, the Kussmaul's breathing. Metabolic alkalosis, it decreases the ventilation. Respiratory acidosis. So what is going to do it? It is going to increase the reabsorption of the bicarbonate, that is in the proximal convolute tubule, or it is going to increase the renal excretion of the H plus, that is in the distal part. Opposite will be in the respiratory alkalosis that is going to happen. So the body is going to do this. Now it might be completely compensated. Usually certain chronic diseases, it compensates. Uh, but the acute diseases, the compensation will take time and that might cause death of the patient if we wait for the compensation to happen. So this is the basic part of the physiology. Now let's go on to the steps of interpreting the ABG, various steps. So as we have already discussed, we are going to think whether it is acidosis or alkalosis. So that's the first point. pH less than 7.36 is acidosis, more than 7.4 is alkalosis. Next, look for the PCO2 and HCO3, narrow down which is the definite process, whether it is metabolic or it is respiratory. As we've already discussed, the Rome and that's the mnemonic, respiratory is opposite and metabolic is uh, towards the same side. So that is how you identify it. So you identify what is the process which is primarily governing. So is it respiratory acidosis, metabolic acidosis, respiratory alkalosis, or metabolic alkalosis? This can be done very easily. Please remember, compensation would shift the other values a little this side, that side, but still the primary disease will always be strong. So supposedly if you have H plus, which is more, then if you know it is acidosis and it is metabolic acidosis that is there. Whereas we're seeing bicarbonate related, it is metabolic acidosis. Whereas the PSO2 related would be the respiratory problems that you're looking at. Next, check for the compensation. So whether the compensation has happened or not. So if the pH is near normalized, then you know the compensation is almost complete. Otherwise, it is partially compensated that you see there. Now, there are various methods or various formulas that you have to remember for the compensation that can happen. So, the change in the PCO2 per change in bicarbonate in a metabolic acidosis is 1 to 1.5 per 1 milliequivalent change of the bicarbonate that is there. Whereas in alkalosis, it is 0.25 to 1.00 per 1. So just remember this first column, if you can remember that. So that is how you remember this. Respiratory, it's a little more complicated because both acute and chronic things happen in respiratory. Metabolic, it's usually acute only. In an acute respiratory acidosis, one change of PCO2, there will be a 10 change in bicarbonate. Whereas chronic, it is 4 change of PCO2 increases the bicarbonate by 10. So that is how the 1 and 4 for the acute respiratory acidosis, whereas uh, in acute respiratory acidosis, the bicarbonate falls, sorry. One PCO2 increase will decrease 10, whereas 4 in this one. In alkalosis, it's again 1 and 4 only we are thinking, but there it is a rise that we are going to say. So what we mean is the change. Change would either mean rise or a fall. For an acidosis, it is a fall. For the alkalosis, it's a rise. So remember, this acute or chronic cannot be given in the ABG. Acute or chronic is a history. That is very important. So here is the history that will tell you. So the respiratory disorders, whether it is acute or chronic, it's only the history that is going to help you. You cannot identify that based on the ABG alone. So history is very important in such case. It is important for metabolic disorders also. So again, remember, for the acute respiratory, it is 1 is to 10 and chronic it is 4 is to 10. Same for the, so this is a simple way to remember. There are more detailed formulas. I will not go into the detail of this. Maybe the PPT, I will share it later. The participants can use it. For each of them, we do have compensations. And this is the table of compensations. Again, I told you, when it's a fully compensated, the pH will be normal. Whereas partially compensated, it will not be normal, but you will have some amount of change that could happen. So based on these values, you can grossly interpret, but please remember your primary history. Whenever the case scenario is given to you and asked to interpret, look at the history, only then can you make the complete diagnosis. So determine whether the acid base simple or mixed. So check the directions as we have already discussed. So same direction which is happening, it's a simple acid base disorder. If it is opposite, it is going to be different. So if you see the primary change in metabolic acidosis is a decreased bicarbonate. The compensation happens is by decreasing the PaCO2 and the pH will effectively that will be low there. In metabolic alkalosis, the primary change is an increased bicarbonate that's there. The compensation is going to happen is by the increasing the PCO2 and that's how the pH will normalize later. Opposite will be in the respiratory. So remember in the metabolic, it's all going down or all going up. If it is respiratory, primary acidosis, the PCO2 is increasing, the bicarbonate also will increase, the pH is low here. Whereas respiratory alkalosis, the PCO2 is decreasing, bicarbonate will be low, pH will be higher in that case. So you can look at these, and if this is not fitting into any of this, then we are dealing with a mixed acidosis problem that is there. Again, you could use various other methods to look for pure acid-base disorders. Let's go on to a few examples before we come into this. So you have a 20-year-old diabetic who has been admitted with lethargy, polydipsia, polyuria, and you're finding here the ABG report. The ABG is showing a pH of 7.24, PCO2 is 24, and bicarbonate is 10 milliequivalents. So I've already told you the normal value. So what is the other reports which you can see here? Sodium is 138, potassium, RBS is very high, and urine ketones is positive. So we know this patient has a diabetes with a very high sugar and urine ketones. So you know this patient is having a diabetic ketoacidosis. So even without making out the ABG, you know that this could be a ketoacidosis problem. But then is it confirming with that, with our diagnosis that's there? So pH is 7.24, so acidosis is present. That's the first step. Look for the PCO2 and HCO3. Both are decreased, which suggests that it's a metabolic acidosis. So you find this is also decreased, this is also decreased. So you know it is a metabolic acidosis is present and calculate the compensating response. So here we are expecting the PCO2, expected change in the PCO2 is 14. That is what is expected there. And that is almost what is done there. So you're saying from 40, around 40, 45, 36 to 45, it has come there. So determine whether it's a disorder which is a mixed or a simple. So is there a metabolic component? So HCO3 and PCO2 both are decreased. So you know this is primarily it is an expected value. So there is no mixed component. So it's a primary simple acid-base disorder that is found. What we saw in the earlier thing. So you know this problem is metabolic acidosis, possibly secondary to diabetic ketoacidosis that you're seeing here. Now here we have a 72-year-old woman who is having a brain tumor and now has come with problems, acute change in the mental status of 1 hour ago. She's comatose, exhibits the Kussmaul breathing. CT is showing a bleed that's there and the midline shift. So you know there is a higher center that is getting affected there. Here when we see the pH 7.57, PCO2 is 20, HCO3 is 20. So you know it's alkalosis. That's what the primary defect that you're seeing there. PCO2 and HCO3 are both suggestive of a respiratory alkalosis. So it's probably a primary brainstem problem that you're seeing there. Expected HCO3, that's how you want to calculate. So 22 is bicarb minus 2 that you're seeing. So you expect it as 20. It is in the expected range. So actual is that much. So both PCO2. So this is again a simple disorder. So what is the disorder? It's an acute respiratory alkalosis this patient is having, probably due to the central problem, that is the brainstem which is got compressed because possibly the patient has herniation that's there. The other important point that we have to understand, very common questions are going to be asked more often with the metabolic acidosis. So once we have narrowed down it as metabolic acidosis, it can result from various forms, either by increased acid, like in diabetic ketoacidosis, or loss of bicarbonate as occurs in diarrhea, or it can happen due to diminished renal excretion, like you have the renal tubular acidosis, or it can happen to that. So these are the three mechanisms of metabolic acidosis. So when we have identified metabolic acidosis, the next process that we are going to do is an anion gap. Now, what do you mean by anion gap is the measured cations minus the measured anions. So you're going to use sodium minus bicarbonate plus chloride. So potassium we are not using. So normally value of an anion gap is 12 to 16. Okay, so 8 to 16, so 12 plus or minus 4. That's the normal anion gap that we see. Now, this anion gap is due to the unmeasured anions, which we don't normally measure. So, it could be due to various albumin related products, it could be due to phosphates, it could be due to organic anions, which are there, which is difficult to measure. So, that's where the anion gap is coming. So we classify the metabolic acidosis into high anion gap metabolic acidosis or normal anion gap metabolic acidosis. So high anion gap metabolic acidosis and normal anion gap metabolic acidosis. So as we said, we have increased anion gap in these causes. Lactic acidosis, where the lactate is being produced. Most common is sepsis. You can have it due to drugs. You can have it due to hypotension. It can happen due to acute kidney injury. It can happen due to acute heart failure, muscle breakdown. Lactic acidosis can happen. Ketoacidosis is very important. Please remember diabetes is an important cause, but please don't forget the other two causes, that is the starvation and alcohol associated ketoacidosis. These are other important causes. Next is the ingestion. Methanol, ethylene glycol, toluene and aspirin. These are the ones which increased anion gap acidosis happens. Now, very important disease that we have is the renal failure, especially CKD. This is one thing a little confusing. Many a times CKD produces increased anion gap acidosis, but sometimes the CKD, the tubular function gets affected, in which condition you produce normal anion gap acidosis. So CKD is an example for both based on what type of disease has produced the CKD. Once the patient is in end-stage renal disease, it will produce only increased anion gap. But before that, you can have normal anion gap acidosis also in CKD. The classical example for normal anion gap where the acid is not added, but there is a loss of bicarbonate, either due to diarrhea or intestinal drainage, post-operatively they will put some drains, etc., or your renal tubular acidosis. So renal tubular acidosis, be it proximal or distal or the type 4 renal tubular acidosis, all of them will produce normal anion gap acidosis. That means the anion gap will be between 8 to 16, that's it. Other important is the toluene injection. Toluene injection, as well as patients on carbonic anhydrous inhibitor, a high dose of acetazolamide, if they are there, bicarbonate is excreted. So you'll have a normal anion gap acidosis. Also, urethral diversion. Supposedly, the urethra has been put into the ileal loop, so there is some sort of a loss that is happening through the intestinal part there. So you can have this normal anion gap acidosis. So please remember this table is very, very important for you for your MCQs about the anion gap acidosis. Majority of your ABC questions are going to be dealing with metabolic acidosis itself and one of these mechanisms. So the history is very important because all of this, what I've told you in this slide, is all going to be on history. Supposedly they say diabetes or the patient has sepsis or the patient earlier metformin causing lactic acidosis, some antiretroviral producing anti, or they are consuming certain methanol or the patient on CKD, you will have to identify. And remember the formula for anion gap and what is normal and what is increased anion gap. This is increased anion gap and this is normal anion gap. A little modification of this, what has come up, high anion gap metabolic acidosis, you have acronym that has been suggested. Earlier we used to say it as mud piles, now it's called as CAT mud piles. Now C stands for carbon monoxide, cyanide, congenital heart diseases sometimes, especially TOF you can have it, where there's failure. A stands for aminoglycosides. T stands for toluene. So again, remember I told you toluene can cause normal anion gap also. CKD also can cause that. Blue sniffing that produces that, or theophylline. M stands for methanol, U stands for uremia. Again, remember uremia can produce both. The D stands for diabetic ketoacidosis, alcoholic ketoacidosis, and starvation ketoacidosis. P stands for paracetamol, phenorphine, that's a metformin, and the paraldehyde. I stands for INH, iron, and inborn atoms of metabolism. E stands for ethanol and ethylene glycol, and S stands for salicylates. So this is one acronym you should remember, the CAT mud piles. for high anion gap metabolic acidosis. For normal anion gap metabolic acidosis, remember renal tubular acidosis, diarrhea, urethral diversion, and you could have it in CKD also sometimes. One more thing which is not usually asked is the urinary anion gap. Now this is important. So urinary anion gap is again sodium plus potassium minus chloride. Here you're not using bicarbonate. So normally the urine anion gap is 0. So in metabolic acidosis, the accretion of bicarbonate should increase so that the renal acidification is intact. So if the urine anion gap is negative, that means the renal tubular acidosis is what we are uh, affected. The ammonia secretion is not happening. So this is very, very important in conditions like the hyperchloremic metabolic acidosis. This can happen when there is a free loss of water, which could happen in gastric outlet obstruction or a continuous GI drainage, or if they have done a surgery, and then such conditions you can get this. So you don't really need to do it in all cases. It's important for the GI losses. So I'm not going into that detail. So whenever you're taking of metabolic acidosis, look for history of drugs and toxins, look for diabetes, look for alcoholism, and look for signs and symptoms or history of uremia. Urine only oxalate, so that is one feature for the renal tubular acidosis, and recognizing in the setting for the lactic acidosis, which can happen very often in shock. The patient who has come with shock, the BP is not recordable, it is lactic acidosis. Intestinal obstruction, leukemia. So you have a lot of lactate that is there in these forms. Again, look for the underlying cause, very important. Kussmaul's breathing, as I told you, is pathognomonic of metabolic acidosis. And this acidosis can result in myocardial destruction and coma in severe cases. So our aim of treating metabolic acidosis is to correct the pH more than 7.2. If the pH is less than 7.2, either we have to emergency hemodialyze or you have to give the bicarbonate correction. So very, very important, please remember bicarbonate when we give boluses can cause severe hypotension. So you have to make sure that the blood pressure is maintained. Only then you give the bicarb correction that is there. Briefly about the metabolic alkalosis. So metabolic alkalosis could be due to the GI H plus loss, which commonly happens in nasogastric aspiration or gastric outlet obstruction. Sometimes it could be due to thiazide diuretics, or sometimes it could be associated with hypokalemia, that's there. And it could be due to the drug administration, like you can give bicarb, it can happen because of that. Sometimes it can be due to the villous adenoma resulting in severe diarrhea and volume contraction. Uh, Usual clinical features, these are associated with electrolyte disturbances, especially potassium. Remember, metabolic alkalosis associated with hypokalemia, and that can result in neuromuscular instability. Always remember, metabolic acidosis should have hyperkalemia. It goes hand in hand. The only type of metabolic acidosis which is not associated with hyperkalemia is renal tubular acidosis. So you find a metabolic acidosis patient and the potassium is normal, your straight diagnosis is renal tubular acidosis. Otherwise, metabolic acidosis should be associated with hyperkalemia. So whenever we are dealing with the metabolic alkalosis, we are looking at urinary chloride. So you have a low urinary chloride or a high urinary chloride. Again, you do get a lot of MCQs on this table. So you have to know a few causes under this. If it's a low urine chloride, that means the renal is already trying to compensate well. It is usually due to vomiting or the gastric drainage or a drug induced. Now, if there is a high urinary chloride, you are going to look for whether the patient has a normal blood pressure. If you have a normal blood pressure, please remember two syndromes, Barter's and Gittelman. So Barter's and Gittelman are normal blood pressure. They are normal blood pressure. Now, if the patient is hypertensive, next you have to look for whether the aldosterone is high, low, or normal. So you are looking both for aldosterone and renin. If you have normal aldosterone and normal renin in a hypertensive patient who has metabolic alkalosis, our diagnosis is only one, that is Cushing syndrome. So please remember this table. If the patient has a metabolic alkalosis with a high urinary chloride, hypertensive, normal aldosterone and renin, we are dealing only with Cushing syndrome. Now, if the patient has a high aldosterone, it can be due to either with low renin or a high renin. High renin, high aldosterone, it is a renin secreting tumor, renin secreting tumor, or a renovascular hypertension. If you have a high aldosterone, no renin, it is primary hyperaldosteronism, otherwise called as Conn syndrome. Conn syndrome is high aldosterone, low renin. So you calculate the ratio, the renin to aldosterone ratio, and that's how you calculate. Now the third entity is where you have low aldosterone and low renin. That is because of one syndrome called as Liddle syndrome, or you could have exogenous mineralocorticoids, like the patient is on fludrocortisone for some reason, or they are on carbenoxolone or a glyceric acid. That's a very rare component. So three important syndromes are asked very commonly: Barter's and Gittelman's and Liddle syndrome. So please remember, Barter's and Gittelman's have normal blood pressure. The Liddle syndrome has a hypertension, low aldosterone, low renin. Hypertension, normal aldosterone, normal renin is Cushing syndrome. Hypertension, high aldosterone, low renin is Conn syndrome. Hypertension, high aldosterone, high renin is renovascular hypertension. So please remember this combination. Very, very common MCQs asked for you in your uh, NEET. Metabolic alkalosis treatment. So very important is to supplement saline, and based on the hormone what we have assessed, we can supplement or use the uh, uh, you can use any one of the treatment for the specific causes that are there. So I think we're almost finishing an hour of it. So these are the main acid-base abnormalities, and predominantly what is going to be asked is metabolic only. Respiratory, I told you, primarily is history-wise. Acute and chronic, you'll be only able to make out by history. Very commonly, what we get is the patient who has an IC bleed, intracranial bleed, what we discussed in the example where the patient is having uh, hypoventilation, and because of that, the carbon dioxide is retained. Or else a very common question they ask you, a young female comes with a casualty with tetany, and when you examine, she has a respiratory rate of 30 or a respiratory rate of 40. So she is obviously hyperventilating. Carbon dioxide is getting washed out, and that is causing the respiratory alkalosis. COPD is one area, very common cause where you have an obstructive airway disease. So there is an obstruction, so the PCO2 is retaining there. So because of that, the patient has a respiratory acidosis, which would be a chronic respiratory acidosis. A patient with an acute anaphylaxis or an acute asthmatic attack or a foreign body obstruction, where there will be some amount of air trapping in some part of the lung, the rest of the lung is normal. The PCO2 rise may not be that high. So that is an acute respiratory acidosis that you would see. So I think this is something very basic approach to the acid-base disorders that I have discussed. If there are any questions, I will take. I think the initial question that is asked was regarding ABG to be cooled. That is basically to make sure that as I said, up to 15 minutes you can keep it like that. But more than that, you would want to maintain the temperature so this oxygen dissociation doesn't happen. The oxygen doesn't dissociate. So that is at a lower temperature, the oxygen dissociation does not happen. That's why we keep it in a place. So primarily, what are the questions going to be asked is related to metabolic acidosis only. As if you see the earlier uh, newspapers or whatever, you have metabolic acidosis itself, which are going to be asked. And metabolic acidosis, primarily the questions are related to either it's a high anion gap or a normal anion gap. So those are the questions which are predominantly going to be coming. So you will have to look into that.